Welcome back, everybody. This is another case of a Phaco DMEK that we did just this week, and there is significant opacity and central edema. And as we usually do for our Phaco DMEKs, we start out with the rexis under irrigation, as we used to under an AC maintainer, but this time we just use the irrigation from the Phaco machine. And since the visibility is so poor, we start off the rexis with assisted tone, but then continue along with the coaxial forceps. We also use the irrigation while fashioning the main wound because we simply don't want any viscoelastic in the AC during this surgery. The Phaco part hydrodissection and sculpting quad and everything else proceeds normally, but we've switched the microscope light to only stereocoaxial. We shut off the paraxial illumination just to get better contrast, and this makes the video very dark. This is because the camera that we are using to film has a limit on the upper ISO, so the video looks dark. But this will soon be solved after we're done with the cataract part, because then we're gonna turn on the lights to get a better view. We use the stereocoaxial illumination just for contrast. It's a bad video, but it's a safer surgery with the better contrast. So also while injecting the IOL, we don't use viscoelastic, and most IOLs don't do well with this kind of setup, simply injecting them. Under BSS, it's kind of difficult, and this IOL model usually comes out trailing haptic first, leading haptic straight, sorry. But that's not usually a problem. So now we're using air to maintain the AC with no maintainer, so simply one air bubble, and then we're very careful to pivot in the wound so that air doesn't escape. And we're using the reverse Sinski to create the 8mm decimeter rexis, and we're using marks on the cornea to guide us, and then we're trying to unite the circle with the main wound so that we get a bit of a yogurt cap shape, a circle, and then the whole 2.4mm main wound as a continuous strip of decimase. And this is very well visualized under air. And then as a whole sheet of tissue, we take it out through the main wound. And we're using the vitrector to create the inferior PI, and then we're visualizing the vitrector through the back of the pupil to be sure that it's patent. Now we're injecting the graft. This is an 8mm graft, simply because we found that in our practice, the retrobulbar block that we get almost always induces a high posterior pressure, and a larger than 8 in this case would have led to a more complicated surgery, with the graft being very difficult to maneuver in the AC. But in this case, we've slowly injected the graft, maintaining proper orientation, and now we're in a winning position with the graft already. We just injected it, and it's right side up. We're using a few Duracimer taps to get it to unfold inferiorly, and that's gonna mostly be it for the surgery. The graft is a bit nasal, so we're gonna fix that in a moment, but we take the winning position as is. We're injecting one small air bubble and then refilling the AC, and then we're using coaxial forceps to drag the graft over nasally from the nasal angle to the temporal wound to center it inside the marks, and then being very careful to take the forceps out. Final air fill. Thanks for watching.